Classical swine fever. Flaviviridae has the pestivirus genus. It's a single-strand RNA virus. It's enveloped and it has moderate resistance. It survives in the feces and the mucus and it's protected for weeks, and direct transmission occurs. Classical swine fever. The occurrence first happened in the USA. It was known as hog cholera. In the 1970s, there were eradication programs in the European Union, and countries became free of classical swine fever in domestic pigs. However, in 2022, cases were reported in the European Union that it has been sporadically reintroduced. It's becoming endemic in wild boars. The disease is endemic in Southeast Asia and South America. For the etiology of the disease, pestivirus C, also known as classical swine fever virus, is a part of the pestivirus genus. There is one serotype, which has 3 genotypes and 4 subtypes. There is virulence variance. Lower virulence is more tricky because it's causing subclinical infections, which allows for long-term shedding. For the epidemiology, there's moderate resistance. It survives in the environment in 4 mites and in humans, raw pork, products, and meat and in waste. The virus is shed in the feces, semen, and discharges. The host is stenoxin. Only domesticated pigs and wild boar are affected. The infection can occur through the oral nasal route, conjunctival, and it can be iatrogenic and transplacental. There is horizontal and vertical transmission, and intrauterine infections can cause immunotolerant piglets. For the pathogenesis of the disease, the virus typically enters the body through the oral nasal route, and then during this time they're shedding within the first 24 hours during the incubation period. But then the primary replication happens in the lymphatic tissue in the tonsils, and then viremia occurs, and then secondary replication happens in the lymphoreticular tissue in the spleen, bone marrow, and lymph nodes. This can cause immunosuppression, which allows way for secondary bacterial infections. The virus replicates in the bone marrow, which leads to thrombocytopenia, which then causes DIC, which leads to hemorrhages. The virus also replicates in the blood vessel endothelium, which causes damages to the blood vessels, which also causes hemorrhages. The virus has 2 courses, the typical and the atypical. The typical has a peracute, acute, subacute, and chronic infection. The chronic infection has shedding. And the atypical is a special form. There is necrotic pneumonia and diphtheric colitis. For the clinical signs, it depends on the course and the virulence variance. In a peracute infection, we see fever and sudden death. In an acute infection, there's the incubation period, then the atypical signs, so they can have fever, depression, anorexia, and then the typical signs after 1 week. They can have dyspnea, circulation problems, cyanosis in the ear, skin, and central nervous system signs such as ataxia, weak hind limbs, and convulsions. They can also get hemorrhages on the skin, and they can die. They often have constipation and then diarrhea. In the chronic form, the incubation period is around 1 month. We can see atypical clinical signs, and this is a problem because of shedding. They get recurrent fever, diarrhea, salivation, anorexia, and depression, and then they can have death at around 3 months. In the low virulence strain, it's subclinical or there can be fetopathy. The wild type still circulates in vaccinated herds. The clinical signs are seen at around 6 to 12 weeks old piglets because of the maternal antibodies. In pregnant sows, we can see abortion, stillbirth, fetopathy, and immunotolerance in the first half of pregnancy. In the pathology, in the acute form, we can see hemorrhages on the mesentery, cirrhosis surface, kidney, bladder, and basically everywhere. On the spleen, we see hemorrhages and infarcts, and we can see hemorrhagic enteritis, and then blood-filled lymph nodes. And the larynx also gets hemorrhages. In the subacute form, we can see buttons in the large intestine, necrosis, enteritis, necrosis in the larynx, splenic infarcts, pseudomembranes, and Croup pneumonia. In the chronic form, which is atypical, we can see costal bones and cartilage development problems. And in the intrauterine form, we can see cerebellar hypoplasia. For the diagnosis, African swine fever has no neutralizing antibodies, whereas classical swine fever does have neutralizing antibodies. It is E2. For the diagnosis, we look at the epidemiology, clinical signs, and post-mortem lesions. These all raise suspicion, but since it's a notifiable disease, it's obligatory to do lab diagnostics. We can detect the agent directly using a real-time PCR, isolation, but classical swine fever has no CPE, unlike African swine fever, which has CPE. We can also do IF. And to detect the virus indirectly, we do viral neutralization, ELISA, and MAB. There is cross reactions between bovine viral diarrhea, border disease, but the neutralizing antigen is E2, and monoclonal antibodies are used. For prevention and control, in the European Union, classical swine fever-free countries are prohibited to use the vaccine. This is because the vaccine can cause possible circulation and it's transplacental. However, there is an emergency vaccine in the case of an outbreak, and it's approved in the EU. You need to control pig transport and trade, and there needs to be no pigs or pig products imported from endemic areas. The virus is isolated within wild boars. In the case of an outbreak, have stamping out, have movement restrictions, and have cleaning and disinfecting. In endemic regions, there is vaccination. There's an attenuated vaccine. It is produced in rabbit cell cultures. In wild boars, they tried an oral vaccine in Germany and Slovakia, but it's labour intensive, and the immunity is not that good. The oral vaccine is not a marker vaccine. Hungary has a northern countries restriction zone, so this includes Slovakia, and there's contingency plans such as hunting and carrying out serological surveys.